Guys, welcome to my YouTube channel Resident Not 7. I have created this YouTube channel especially for helping NEET PG and INI-CET aspirants as well as MBBS students who are struggling with core medicine topics. I am here to help you guys, so kindly subscribe my channel and hit the bell icon below. Thank you.
Hello guys, welcome to my page Resident Not 7. Today we are going to see about ventricular tachycardia, which is a very important topic considering INI-CET preparations and NEET PG preparations as well. So without wasting much of our time, we will dive into the topic. So our topic of discussion today is ventricular tachycardia. So coming to ventricular tachycardia, it is a ventricular rhythm. As you all know, it is an unstable rhythm and it suggests cardiac arrest. So before going to that, we will see a case. A 50-year-old male, he presented with new onset chest pain since 12 p.m. in the afternoon. So as he was having chest pain, ECG was done, and ECG was showing T wave in the ST segment depressions in V5 and V6 as well as 2, 3, and AVF. TROP-I was done; it was positive. So this patient was having chest pain, which is a typical cardiac chest pain, along with the typical ECG changes suggestive of NSTEMI or unstable angina, and TROP-I was 7.3, which is positive. Hence, this goes into the category of NSTEMI. If enzymes are normal, this would have gone into a category of unstable angina. Okay, so NSTEMI was diagnosed. So what's next? So patient was received and patient was given loading dose of aspirin, clopidogrel, and atorvastatin. And since this is an NSTEMI, thrombolysis is not an option. So patient was given injection heparin, unfractionated heparin, 5000 units, IV QID, that is Q630. So this is the usual management. Patient was planned for PCA. So I think this much you can understand, the CAG plus PCA. So at 3 a.m., 3 p.m. in the evening, patient was found gasping. So patient was showing signs of hair hunger and he was found gasping, and monitor was showing this. As you can see clearly, there is broad complex rhythm. Can you see here? Yeah, these things are called as ventricular tachycardia. So ventricular tachycardia was diagnosed. So as an emergency resident, what should we do? So that will be a question. And patient's BP at that time was 60/40, and he was showing this broad complex tachycardia at rate of 200 per minute. What will you do? So this is the ECG showing broad complex tachycardia suggest your VT, and patient's BP is less than 96. So patient is hemodynamically unstable. So this is VT. Before going to the treatment, we will see what is VT. VT is 3 or more ventricular premature, that is ventricular complexes in a row with rate more than 100 per minute. And what is monomorphic versus polymorphic VT? If all the complexes are of similar morphology, it is monomorphic VT. If complexes are having different morphologies, then it comprises polymorphic VT. So once polymorphic VT is coming here, you should also know about another condition called as Torsades 3-pointers. Or polymorphic VT and Torsades 3-point is the same? No. Polymorphic VT with prolonged QT interval is Torsades. So even if patient is having polymorphic VT, but QT interval is normal, then it is not Torsades 3-pointers. The commonest cause of Torsades 3-pointers is hypokalemia and hypomagnesemia. So prolonged QT is a first drugs. Yeah, prolonged QT is a prerequisite for process 3 pointers. So why VT? So we are going to see why VT happens. VT is an ventricular rhythm, as I already told. It is a disease of structurally abnormal heart. For example, MI, where scar tissue will form. I will explain later how scar tissue increases the risk of VT and sudden cardiac death. We'll come to that later. And 10% it can happen de novo also without any structural heart disease. And it is, as I told, it is a byproduct of MI, myocardial infarction. So let us see how the ventricular tachycardia happens. So ventricular tachycardia is a arrhythmia of re-entry. Very, very important question. So normally we will see a impulse coming from SA node to AV node to his bundle, then Purkinje fibers. From the Purkinje fibers, the impulse has to go to the muscle, right? This much you are very well known about. Suppose Purkinje fiber is coming and it is dividing into two twigs. One stronger impulse is going here and one weaker impulse is going here. And here scar tissue is present. Here normal myocardium is present. Scar tissue is present due to previous MA. So this is a depressed region. So already a weak impulse is coming here. This weak impulse can't go through this depressed region and it will get suppressed and it will die out. But the strong impulse is already going here. It will go and it will take a circular path and then it will reach the depressed region here. Here the depressed region can only block the weak impulse, but the strong impulse can't be blocked by this depressed region and it will form a re-entry circuit. So this leads to a phenomenon of re-entry and continuous re-entry process leads to ventricular tachycardia. If only one re-entry circuit is there, it forms monomorphic VT. If multiple re-entry circuits are there, it forms obviously polymorphic VT. So another important prerequisite for VT to happen is there are two circuits, right? One first circuit, second circuit. The refractory period of the first circuit should be short such that when the stronger impulse arrives at the depressed region, it should be able to conduct rapidly along the first circuit where the depressed region is present. Hence, the rule is the refractory period of the depressed region should be short so that the re-entry can happen without any difficulty. So again I am telling SA node is there, AV node is coming. So SA node is there, AV node is coming here, and from AV node his bundle is coming. From his bundle two twigs are arising, that is pulmonary Purkinje fibers are arising. From Purkinje fibers two twigs are happening. Okay, this much you understood, I think. So the Purkinje fibers are divided into two twigs. A weak impulse goes there and a strong impulse goes here. The weak impulse reaches a depressed region due to previous MI. Hence it dies out. It is not conducting. Now the stronger impulse is coming. It is conducting the normal LV myocardium and it reaches the depressed region. Here the depressed region won't be able to suppress the stronger impulse. So it will conduct. So this conduction leads to the end of that Purkinje twig and it forms a circuit. But for a stronger impulse to conduct through the complete the circuit, the refractory period of this circuit should be less, so that by the time the stronger impulse arrives near the depressed region and the end of the another tweak, the refractory period will be over and the seamless conduction can happen. So this is the concept. So management. Coming to the important part, how will you manage VT? We have to give DC shock if patient is unstable. You can give 200 joules DC shock unsynchronized. If patient is again having VT, then again you have to shock. But in the meantime, you have to put IV antiepileptic, particularly IV amiodarone, 150 mg IV or IV lidocaine 100 mg IV. So this will lead to the resolution of arrhythmia. But you have to look for prolonged QT. You have to look for ischemia. You have to look for potassium, magnesium. If they are abnormal, you have to correct it. Because you have to always find the reversible causes of the arrhythmia. Suppose the patient is hemodynamically unstable, that is BP is more than 90/60, nothing to do. Give amiodarone, lidocaine, and the dosage of which I will tell now. So amiodarone, as I told you, have to give 150 mg IV stat, then start an infusion at 1 mg per minute for 6 hours, followed by 0.5 mg per minute for 18 hours, followed by 400 mg TDs for 1 week. So this will lead to a loading dose of nearly 10 grams over 1 week. And this should be followed by 100 mg BD. The commercial form available is Orderone, that brand name. And you can also give IV lignocaine, which is also called as Xylocard. You can give 100 mg IV stat. This can be given as maintenance dose because lignocaine has more serious side effects. Particularly for VT associated with TMI, we can use this. So always treat the cause. Always look for serum. Always look for serum potassium, magnesium levels. Look for ischemia. Since these two are the most common cause of VT, in 10% of patients, VT can happen de novo without any structural heart disease. So if ACS revascularize, if due to lateral abnormality, correct it. If not reversible and patient is having VT, then ICD can be placed. So this is the ICD device. This is the ICD coil. ICD is implantable cardioverter defibrillator. So this is the ICD coil. This senses the patient is having VT or VF, as these two are the shockable rhythms and shocks. The shock is DC shock. Yeah. So this summarizes the end of the topic called as ventricular tachycardia. So take home points should be: number one, ventricular tachycardia is an unstable arrhythmia and it should be treated in an emergency setting immediately. If patient is having hemodynamically unstable BP of less than 90/60, you have to shock the patient with DC shock. If patient is hemodynamically stable, you can try amiodarone or lignocaine, both IV. Amiodarone at the dose of 150 mg or 300 mg IV stat, followed by infusion. Lignocaine stat dose only 100 mg IV. And this can also be given as infusion, but mostly we will give amiodarone as infusion. And always treat reversible causes, particularly ischemia, number two lateral abnormalities, including hypokalemia and hypomagnesemia. If patient is having high risk of ventricular fibrillation, particularly heart failure patients who are at sudden risk of cardiac death, we can always place an ICD for these patients. I hope this session was useful. If you find this session useful, follow my YouTube channel, Resident Not 07, and press the bell icon below. I hope this is useful. Thank you.